we have one specific subluxation pattern that's showing up three different places: the jaw, the eye, and the torticollis. There are not three separate issues. There are three windows into the same issue. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. Subluxation slayer. Let's say you have a referral partner, like a lactation consultant, and they have a list of referral partners from a chiropractor who maybe they know about range of motion, maybe they know what you or not, to a craniosacral therapist, to an OT, to this, to that, and your whole conversation about when they should refer to you is based off of the symptoms, the feeding difficulties, whatever else. And they have all these different referral partners. And it's just like, okay, so you can help with any feeding difficulty. So when should I refer to you and when should I not? And there's just a little bit of confusion. Unless you give them something very, very, very specific that they can take home, right? It's going to be challenging to remember you for more than days, weeks, more than that. So we want to arm them with something very, very, very specific, right? And in the same way that when we ask for like a specific referral or something else like that, it's like, do you know anyone? No. Anyone who could benefit? Like, no, I don't know anyone. It's like, do you know one person? Well, yeah, I know one person. So rather than saying, hey, just refer me anybody with a feeding difficulty, we want to arm them with some specific finding that they have, that they know when this occurs, that is the number one thing, like I am the person to help this. So today we're going to talk about something that we mentioned in episode 12, which is I learned from Dr. Lisa Geiger, who I always credit, but she reminds me that she got this from somebody else, and I just forget who that other person is, and that is going to be Jet syndrome. So 4-month-old goes into your office. Mom says that the pediatrician called the Torticollis sent her some stretches and sent her home. They didn't mention any of the other pieces there, didn't mention anything else. It was just like, Torticollis or not. 3 months later, she ends up in your office and you look at the baby in front of you and you're like, oh my gosh, how has all of that been missed? You see the face, you see the distortion, you see everything else, and you're like, how do we just chalk this up for their pediatrician's mind torticollis and not something more that was going on, or how do we not get them to chiropractic office for the torticollis to begin with? So Jet syndrome is what we effectively refer to as jaw, eye, and torticollis being off all together. So this is not a diagnosis. It is not a disease. It is not even really a syndrome in the way that your pediatrician friends mean that word. It is a cranial and spinal subluxation pattern and what it looks like from the outside when you are standing 3 feet away from them. We have one specific subluxation pattern that's showing up 3 different places: the jaw, the eye, and the torticollis. There are not 3 separate issues. There are 3 windows into the same issue. Again, this is the exact same logic that we have from our episode 12 with the numbers of the craniovault asymmetry index and cephalic index. The parents aren't seeing this as a sphenobasilar torsion subluxation patterns, but what they do see is a jaw that looks off, an eye that looks off, and a head that won't turn. So let's call it what it is. A lot of times the torticollis, chiropractors get really, really, really excited because this is challenges with range of motion in the neck. And we will look at the torticollis and we will look for things like C1, we'll make our adjustments, and we will hope that it gets better, right? Maybe not hope, we expect that it gets better with our spinal specific subluxation correction. However, we forget, again, that a torticollis is a spasm of the sternocleidomastoid muscle. And of course, that attaches at one level at the sternum, and then it moves up and attaches into the mastoid process, which is part of not the spine, but the cranium, the cranial bone. If we have specific constant tugging on that mastoid, of course, what that's going to cause is a rotation of the temporal bone in itself. Whether that is the chicken or the egg, you hear me say this all the time on this podcast, it doesn't matter if the torticollis was downstream or upstream from this issue, but it is going to cause and affect both of these different things at the same time. So this temporal rotation, of course, that is now happening, either causing or being caused by challenges with the sphenobasilar or the frontal that's compensating, or maybe it's compensating for the torticollis or as a downstream effect, or maybe it's the primary subluxation pattern. It doesn't matter which one it is, but what we know is that the temporal pattern is, of course, going to affect the jaw. Well, how do we know that? Is because the T of temporal stands for the T of temporo for the temporomandibular joint, or the TMJ. So, of course, depending on how that temporal bone rotates externally or internally and gets stuck, it's going to move the jaw either towards or away from the side of that subluxation pattern. Okay, so the neck and the jaw are going together here. As we get that pattern where the cranium is now distorting and the jaw is dropping, that is going to also cause rotation of the maxilla, cause changes in the frontal bone. It's going to be, as a result, again, chicken or the egg of the sphenoid, which of course is going to change the appearance three-dimensionally of the orbit, which is going to relate to an eye asymmetry problem. I love the way that this goes, and it's so easy. It's a big three. Everything we do well, we do in threes. And it's just like, boom, when should you bring me into the picture if you're unsure? For me, I'm like any feeding difficulty, right? Of course, we just said, but like if you're unsure and you want to know, check for this. Is the jaw deviating? Can you see a minor eye asymmetry? And is there any sort of cervical range of motion issue? You can just think of it, if you forget, like jet syndrome, J-E-T, jaw, eye, torticollis. Boom. It's just a clinical pattern that is super easy for a parent or for a referral provider to be able to understand and know. All three of these go together. It is just the same pattern. In a plagiocephaly, like when we're seeing this, by the way, this JET, this to me is like an easy thing for somebody to be able to see visually. I am like, by definition, assuming that this pattern is happening in the presence of a plagiocephaly. Because especially with the torticollis, if they don't have the appropriate range of motion, either from an internal subluxation pattern, like where there's a dural restriction and there's sutural restriction that's not allowing the brain to grow evenly, or if because they just don't have appropriate range of motion and they're laying with one side of their head down on the floor all the time, we're going to start to have occiput flattening. Again, what causes it? I think it's important for us to understand that it can be both, so parents can understand that it's both, which is the reason that when they have a plagio case, if they just do the range of motion stuff with the PT, once that suture is restricted, or if the range of motion is caused because the suture was restricted in the first place, it's not going to actually fix the head shape unless that suture is actually corrected, okay? So that's just something really, really important to know. There are outside-in vectors that relate to plagio, but there's also inside-out vectors. We specialize on the inside-out. But when that occiput flattens, now what we're going to have is a torquing pattern. So we think occiput comes across at the sphenoid, at the sphenobasilar. There's going to start to be a torquing at the sphenobasilar, especially if you were to go ahead and track where the falx actually comes across. Now you think about, you twist the falx at the back, then the frontal where it inserts in the front is going to distort as well. So we get flattening of the occiput, and then we get bulging of the frontal bone. The sphenoid, the temporal, and the frontal all relate to issues with the jaw, which we start to look at like when you get into deeper craniopathy. Okay, we start to differentiate, is the jaw issue on occlusion? Is it on opening? Is it on both? If it's occlusion, it typically points more temporal. If it's on opening, it points more to other things. We don't need to educate the provider to know that. They just need to know that this shift is happening when there is a subluxation present, and that you are the person to be able to correct that. So once we have the distortion as well, again, we saw occiput flattening, torsion of the sphenoid, frontal compensation. Now you're thinking sphenoid, frontal forming the different pieces of the orbit with the maxilla as well that rotates, right? And now we're going to be, of course, seeing that appearance of an orbital asymmetry, especially when looking at the face because it's rotated and it looks like one is higher than the other, or just rotated, kind of like that cat's eye appearance where the eyes just don't look even. If their parent is only viewing that, if the provider is only viewing that as a soft tissue issue, they are missing the boat when it comes to this. So now that we've got that, we've educated the people, the kiddos in our office, how do we, and we see the jet syndrome, I don't think that we should just be saying, hey, your baby's face is effed up. but we should be starting to bring in the more clinical measure, in which case we are the expert, okay? Because maybe the lactation consultant or even the pediatrician isn't going to measure the cranial head shape, or they are to put it on a growth chart. We're going to actually measure for the asymmetry. And this is where we get to take it from the layman's terms, visual analysis of Jet syndrome, and now put it into more specific language on our case. We're going to be looking at the craniovault asymmetry index, and we're going to be looking at the cephalic index so that we can both measure and see distortion of the cranium, plagio, asymmetry from the CVAI, as well as the long to short like brachycephalic pattern as well with the craniocephalic index. We should be able to take that, understand those numbers, understand what they mean. Of course, go back to episode 12 if you're not sure, and give them to a parent in a way that is in our language, is not looked at this as the problem itself, but as a downstream effect of a subluxation pattern. So whip out your calipers and measure those. See the Jet syndrome, let them see it, but then come in and lock your measurements and be good enough at this work to be able to get this change over time. If you are measuring, congratulations. If you are not yet, go get your Mimos calipers off of Amazon. I don't have a link because I don't care. You just need it anyway. But what you should also be doing is putting this information into a parent-facing report that is beautiful, that educates them, that is in our language, and not just relying on them getting the information by Googling these different things and they end up in a helmet or being told that what they have isn't a real problem. So if you want help with that, make sure that you go to thecranialdoc.com/calc, and I will give you the free software to do all of your calculations. And not only do all of your calculations, but also create that parent-facing report for you and direct that parent to getting good principled chiropractic information, because we are the authority on this. So we want the parent to be receiving what we know is the correct thing versus the outside-in approach, allopathic model to treating these things, which we know oftentimes does more harm than good. And so that's the reason we're so glad that they are in your office. So let me just one more time, just to reiterate, walk you through what this looks like when it walks in your office. 4-month-old has a torticollis diagnosis already in hand from the physician. They're doing the chest stretches. There's no change in the photos. They're maybe looking at doing a helmet, maybe not. They're unsure. They're really unsure what's going on. Mom has maybe already noticed the eye problem, but they didn't know that it was related and thought it was separate from the jaw deviation, which they also thought was just a cute yawn. Nobody ever flagged it before, but you get to come back and connect it to the same subluxation pattern that you are already connecting on every cranial evaluation. They aren't 3 different symptoms, 3 different indicators that we address, one each on a handful of visits. They are a specific pattern that is showing up in the patient in front of you. So they start shifting from these are 3 unrelated things that maybe they're a problem, maybe they're not, to, oh, there is one subluxation pattern that is in my child that needs to be corrected. That is the major shift. We have 3 different worries, maybe you're not, 3 different small things to end up becoming one story that can change the trajectory of that child's life. And the whole value of this is giving that story a name. And that name is Jet syndrome. Again, same rule for us applies as episode 12. We are tracking the change. We are not just eyeballing it, calling it out, and hope. Craniovault asymmetry index should trend over visits using the same tiers that I gave you before previously in that episode. Go back to that and listen. Go to thecranialdoc.com/calc and read the reports that you can familiarize yourself. We don't need to go and say, hey, the jaw is there and the eye is there, but the torticollis isn't, to make it land for a parent. This is a cluster of findings that show up together. And once we can see and be questioning about whether or not it's a problem, we can use our craniovault asymmetry index and our cephalic index to put the numbers on it, to fully understand what is going on, and to be the authority on this child's care, be the quarterback, and get them to actually make positive decisions that will change not just the symptoms for now, but change the ability for their nervous system to adapt to stress, to grow and develop at 100% for the lifetime. Remember, we never know how far-reaching something that we think, say, or do today will affect the lives of millions tomorrow. Check the jaw, check the eye. You might be the one person putting all of these pieces together. Take the measurements at thecranialdoc.com/calc. Get them face down on your table, understanding what it is that we do as chiropractors, and go slay some subluxations. Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.